the program and communications manager at the Center for Community Resilience at the George Washington University. And I'm just excited to have this opportunity to talk to you all today about how racialized narratives affect you all in the discipline of mental and behavioral health. And so before I begin, I want to share a little bit about what we do at the center and what we do within BCR. So the Center for Community Resilience, which you may hear me refer to as CCR moving forward, is an organization at GW. And we really work to inspire, support, and sustain a movement of communities that can address the root causes of childhood trauma, foster equity, and build community resilience. And we do that by providing technical assistance, facilitation support, data analysis, and policy guidance to really help institutions, organizations, and collaboratives create measurable and lasting change by preventing and mitigating adverse childhood experiences that occur in the context of adverse community environments, which is what we call the pair of ACEs. And so building community resilience, or BCR as we call it, is our flagship initiative. And we've got 6 sites, as you see on this map, across the country who are working within and across their cross-sector coalitions to transform programs, practices, and policy to prevent ACEs. And so our cross-disciplinary collaborative has members in academia, education, healthcare, public health, social services, and government. And the organizations that you see circled in red here represent our partners who provide mental and behavioral health services to children and families. And so you can see it's about half of our entire collaborative. So we at CCR work really closely with organizations like yours. Sorry, I'm trying to do too many things on the screen. Let me move this chat out of the way. Okay. So our work is really rooted in, when you look at this pair of ACEs tree, our director, Dr. Wendy Ellis, came up with this pair of ACEs tree. And our work is really rooted, if you look at it, in changing the systemic drivers, or what we say is in the soil, that are producing adverse community environments, and in turn, those adverse childhood experiences in the leaves that prevent children from thriving and result in long-term effects on mental and physical health. And we really do try to look at the outcomes or the leaves as symptoms of structural issues, which allows us to better support people in communities by asking what happened to you rather than what's wrong with you. So it's really just a slight reframe, but it really changes the way that you can approach the people that you work with. This here is our building community resilience, or BCR, process that really drives all of our work forward. And it involves 4 pieces which happen iteratively and not necessarily in order. So one of these things is establishing a shared understanding of what's happening at the community level to produce adversity, what strengths exist within the community to support resilience, and then what narratives are driving both of those things. And then we also find it really important to be able to assess the state of readiness amongst providers, systems, and policies for change, right? You might be able to go into one place and have a relatively quick turnaround of your practices and your programs, and then go into another organization in a different state and hit a wall. And so as we do this work, it's really important for us to meet people where they are ideologically and in the process of all of the work that they do. We also really rely on building partnerships across sectors to create these multidisciplinary coalitions that can collaborate. We know that inequities that people face come from all different areas. And so it can't just be one set of people or one discipline or one sector working. We all have to sort of be working together to make that change. And so we really push the importance of using that cross-sector collaboration to help change people's material conditions and their health outcomes. And then, of course, we really prioritize, perhaps the most important thing that we work to do is to center community voices and perspectives and prioritize the community's needs in their work. And so if any of you are familiar with a phrase that came out of the disability advocacy and disability rights movements, nothing about us without us, is really the way that we approach the work that we do and the people that we work with. So, when we ask what equity has to do with it, we really feel like equity is at the center of everything that we do. And this bug right here kind of shows our line of thinking. We recognize that a lot of the trauma that we see in people's lives is really driven by systems and policies that were designed to produce inequity. And so in order to get to resilience, we have to sort of walk that back and create equity in those systems and policies to get there. And why I'm focusing on narrative today is that one reason that inequity has been so persistent for so long is that all around us are narratives that really exist to justify or explain away why things are the way that they are. And so part of the work that I do here at CCR is to explore how narratives are operating, and particularly racialized narratives, and help people in the field understand them better. And so in this presentation, I'm going to define public narratives and highlight how they perpetuate inequity, discuss some examples of dominant narratives that influence mental and behavioral health policy, practice, and discourse, and then share some very simple suggestions for how to challenge narratives in your work. And then we'll close with some breakout discussion for you all to sort of reflect on everything that I talk about today. Before we begin, because we're going to be talking about some heavy things today, I just want us all to be prepared to enter into a brave space that allows us to really go beyond our comfort zone and push ourselves to embrace the discomfort that comes with talking about issues regarding race and equity. So some things to remember as I'm presenting, and then also as you break out into the breakout rooms, are really to just listen deeply, expect to experience discomfort, right? And be willing to lean into that, accept one another's reality and that we're coming from different places and different experiences. When you're engaging, ask compassionate questions and engage compassionately. Be willing to challenge yourself on the various things that come up. Be ready, expect and accept non-closure, right? This is we're talking about a lot of things that aren't going to get solved in the next 45 minutes or in the next 45 days or maybe years. And so we have to really be willing to do the work and know that we're not going to come away with a solution right away. Also be willing to allow others to learn something that you might already know. Again, we're all coming in from different spaces. And of course, at the end of the day, the most important thing is to take care of yourself throughout this process. So narratives, narratives are essentially a collection or a system of related stories that represent a central idea or belief. And they exist everywhere and are created by everyone. So a couple might have a narrative about how they met, or you and your sibling might have a narrative about who got in trouble more growing up as kids. These are relatively simple and harmless because they don't really have an effect on anyone outside of the story. But when a narrative begins to shape how people create meaning about the world and their place in it, it becomes known as a public narrative. And what public narratives do is give coherence to group experience. They typically serve the interests of a dominant social group. They often go unnoticed, despite being interwoven in policy, mass media, and corporate and professional discourse. And because public narratives are expressed all around us in subtle ways, over time, they can become widely accepted as fact, regardless of whether or not there is evidence to support their claims. And so what this really means is that the stories or the narratives that are around us and the way that we tell them matter significantly to how we operate as individuals, in community, and as a larger society. And here in America, there are a few dominant narratives that really stand out. So of course, we have individualism. It's a big part of the American narrative. Principles of autonomy and self-reliance are really baked into the way that we're socialized. And what individualism does is creates an assumption that a person's life outcomes are the sum of their personal choices and behaviors, which ignores the ways that socio-environmental factors can affect access to opportunity and choice. And I think, as you see in this picture, another thing that individualism can do is give people this sense that their actions or behaviors or beliefs don't have an effect on anybody else, and that they don't have to consider the people or the context around them. And then we've got meritocracy, which really tells us that if a person works hard enough, they can access economic power and upward mobility, regardless of their gender, their class, their race, any other sort of identifying characteristic or demographic. But by failing to acknowledge that social and environmental levers influence opportunity, that narrative masks the fact that hard work is only going to get a person so far if they're starting from behind. And so we see these narratives and they're around us. And while we might look at them now as I'm talking about them and say, well, we know that's not true, they persist because they've been repeated so many times that they're now deeply embedded into our social consciousness as being true and accurate. And it's important to note that narratives don't always operate on their own, right? They can be used to reinforce and support other narratives. And as an example of that, individualism and meritocracy are, and from my perspective, vestiges of what is the most dominant and harmful public narrative we have in this country, which is the narrative of white supremacy. So I want to start, before we dive deeper into this, by defining white supremacy so that we're all on the same page about what I mean when I'm talking about it in this instance. I think still today, we hear the words and our brains might immediately shift to the individual level, or perhaps see images of white hoods or burning crosses or Nazi symbols. And while I think these are accurate depictions of what I would consider the extremist end of the spectrum, a majority of the expression of white supremacy in America today is hidden and subtle and systemic. And so that's really where we want and need to focus. And so if we look at this definition here from Francis Lee Ansley, white supremacy is defined as a political, economic, and cultural system in which three things are happening. White people are overwhelmingly controlling power and material resources. Conscious and unconscious ideas of white superiority and entitlement are widespread, and relations of white dominance and non-white subordination are reenacted across a broad array of institutions and social settings. And again, I really like this definition because it focuses on systems and gives us a clearer framework for what white supremacy looks like in action today versus in the Jim Crow era or prior. And one thing that I want to note before we move on is that white people are not or people who identify as white are not the only ones who are capable of perpetuating white supremacy, right? People of color can internalize white supremacy. I think particularly the ideas of white superiority and entitlement and the enacting of white dominance and non-white subordination. And so regardless of your race, this is a narrative that we all have to be working against. And so now that we have that shared understanding, I want to focus more specifically on how white supremacy has been historically rooted in the field of psychology, and of course, as a result, in mental and behavioral health as a discipline. So, throughout history, the field has perpetuated scientific racism through the invention of racial diseases, the promotion of theories that justified segregation and racial population control, and the subjection of Black people to inhumane and unethical treatments and experiments. And so this is just, this timeline could be filled out with many more things, but we don't have a ton of time. So I wanted to highlight some things that I thought were sort of striking to me. Starting with, in the 1840s, census data suggested that free Black people in the North were experiencing significantly higher rates of mental illness compared to enslaved Black people in the South. Now, the reality is that these rates were higher because freed Blacks could access care, while those who were enslaved were barred from treatment facilities essentially until emancipation, and even after that found it difficult to find care. But by intentionally failing to acknowledge that context, that data was used to indicate that freedom had a negative effect on Black mental health. And then less than a decade later, in 1848, a doctor named John Galt perpetuated the idea that freedom was connected to mental illness in the Black population by asserting that enslaved Black people were immune to mental illness, essentially because they didn't have to worry about their basic needs. So you have somewhere to live, your basic needs are being taken care of, and you have a job. So, the worries that would create mental illness in people were not applicable to enslaved people, according to John Galt. And then not long after that, in 1851, there was a surgeon from Louisiana. He was also a psychologist, and he was pro-slavery. His name was Samuel A. Cartwright, and he discovered two new diseases that suggested that the desire for freedom and agency was unnatural among Black people. And so I'm probably going to butcher these names: drapetomania, which was the uncontrollable urge to escape slavery, and then dysesthesia aethiopica, which had symptoms that included things like disobedience, destroying property, and refusing to work. And Cartwright's suggested cure for these illnesses was, quote, whipping the devil out of them. And so across these examples, we can see some of the defining characteristics of the definition of white supremacy that I mentioned a couple slides ago, including the ideas of white superiority being communicated through expressions of Black inferiority, expressions of power or dominance, and who was at the forefront of the field as an expert who's putting these things forth. And then white dominance and non-white subordination in both research and practice methodology. And this line of thinking really continued through the 1900s and even up through the 1990s, which is jarring to think about, but real, as the field continued to use its scientific authority to really depict Black people as mentally inferior, childlike, incapable of self-care, and inherently dangerous. And so essentially, the original narrative of white supremacy resulted in the creation of a whole host of these kind of sub-narratives that came to be accepted as valid and true. So I want to point out quickly that, ironically enough, the field's approach to Black mental and behavioral health really began shifting with the end of slavery. So when Black people were under the complete control of slave masters and white power holders, white power holders more generally, their mental health wasn't something that required much attention, right? We had people saying that they were immune to mental health issues. But following emancipation, when Black people were free and gained more agency over their lives and experiences, the field began to treat this population as though they were at an exaggerated risk for mental illness and needed to be controlled and forced into compliance. And so I wanted to share these two Haldol advertisements as examples. So and I would love if people want to come off of mute and share or throw it into the chat, but both of these were from the 1970s. And just a simple question, what differences do you see in the presentation of these two ads?
I can speak up.
Sure.
Hi, Diana Gray, pronouns she, her. The image of the white man is presented with just so much more compassion than the other image. It's very much more like, this person has a mental illness and shouldn't they get the treatment that they deserve? And the other one is very, I'm going to say accusatory. That's it's not quite the right word, but that's just what I'm seeing.
Yeah. I'm seeing, feel free for other people to jump off of mute too, but I'm seeing in the chat, one on the left looks like a villain. The one on the left is distorted, scary looking. There's a difference in self-agency, portrayal of the idea of aggressive versus confused. The one on the left is very negative compared to the one on the right, in imagery, wording, and tone. All of these things are right if you look at the one on the left, I mean, right at the top, assaultive and belligerent, really comparing that to the person that we see who is, to me, is oddly like a James Brown looking character. And so like there's very, very much racialized undertones here. When this advertisement talks about what the drug will do, acts promptly to control aggressive, assaultive behavior, usually leaves patients relatively alert and responsive, et cetera. And so, and also one thing that stood out to me was cooperation often begins with, right? So there's this real undertone of like, the person that you see in this ad needs to be controlled and to comply. And yes, Brian, it's like they demonize us for having the same concerns, but there's a lot more compassion towards the image on the right, which is, like somebody said, it's somebody who's confused, not really sure what's happening with them. I'm trying to read the, most patients. So in this case, this patient needs a quiet, undemanding life that provides refuge from a confusing and overwhelming world, right? So very different ways in which the two subjects in these ads are treated. And I think this speaks to, again, how narratives operate, not just, this isn't hypothetical or theoretical, right? This is in practice how these things affect the way that we view the world and see the world. And so Again, if white supremacy and its sub-narratives existed in a vacuum, perhaps they wouldn't be a big deal, but the reality is that they have an impact on policy and practice. And what that does is results in this reinforcing cycle of inequity that's really undergirded and perpetuated through structural racism. And so we're going to take a look at some examples of how that happens today. So we at CCR created this graphic last year in response to the early data on racial inequities in the pandemic, as well as some of the uprisings that were resulting from anti-Black police violence. And the model can be applied across every system, including mental and behavioral health, and essentially outlines how white supremacy, which is a narrative suggesting that white people should dominate all other races, essentially becomes practically and tangibly reinforced by systems and policies that are designed to empower that belief and in turn create conditions in which white people have the best outcomes across measures of health, wealth, and well-being. And because white people end up prevailing across those measures and have for centuries, we've been conditioned to attribute those better outcomes to whiteness itself, which then reinforces the idea that whiteness is superior, and then the cycle gets triggered all over again. So let's look at a couple of concrete examples of what this looks like. So if we think about the research landscape that informs the way you all do your work, the belief in white supremacy pops up in a few ways. So we know that for a very long time, a large majority of the field was made up of white researchers and practitioners because that's who had access to education and training. And we also know that because of this, whiteness has been deemed the standard or the norm. And I think this still happens in a lot of ways that we compare everything against. And that's meant that much of the research that gets put out doesn't even really consider race. So when we ask, okay, well, how is that reinforced by structural racism? Well, this article showed, or a study showed that from the 1970s to the 2010s, only 5% of publications, psychology publications highlighted race. And of the ones that did, 2/3 of the lead authors and almost 90% of the editors were white. And so the result of that is that racial minorities continue to be underrepresented in the research. So when we ask, okay, well, how does that ensure white supremacy as an outcome? Well, when you're generalizing findings to groups that weren't sufficiently represented in the research, then practitioners end up applying diagnosis standards and treatment modalities with a one-size-fits-all approach. And so essentially, by failing to conduct research and practice that considers cultural and contextual differences that would completely transform perhaps the way that you work with children of color, white supremacy is the outcome because white children become more likely to get the appropriate care while children of color may not. And I want to take just a quick moment to acknowledge like how interwoven and complex this cycle is. When we think about the fact that we're still grappling with a lack of research participants of color, we really can't separate that from the reality that there's a lack of published scholarship of color, which could also be related to the reality that there's a lack of editors of color. And so at every level, from who has opportunities to participate, to who has opportunities to conduct research, to who has the opportunity and the power to decide what is worth publishing, you can see that the narrative of white supremacy is operating and affecting what is available to the field. Okay, and then another example of this is more practical. So, again, white supremacy as a narrative has really created an environment where we see white children as more innocent and their behavior as more redeemable, even when it's not, while Black children are viewed as aggressive or violent and then criminalized and punished, especially at much earlier ages. And so these are kind of disparate examples, but I think it helps to show the difference here. So, thinking about how when I was thinking about this, I was thinking about how police in South Carolina, going back, if you all recall, when Dylan Roof committed the mass shooting at the historical AME church down there, the police that arrested him took him to Burger King after he killed 9 people. And I was thinking about that in comparison to in Orlando. I think this was just last year or a couple years ago. There was a young girl named Kaya Roll who an Orlando police officer arrested her for throwing a temper tantrum at school. This is a 6-year-old. And so she gets arrested for doing something that you would expect someone at that age to do, right? And so I'm going to get back to the example, but I do want to pause here quickly to note that earlier I mentioned that white supremacy isn't a belief that's just held by people who identify as white. It can become internalized in people of color. And as an example of this, the arresting officer who took Kyrol in was a Black man. So, these are real and tangible things that come up for all of us. And so getting back to that example, that stereotype about children of color is empowered structurally and this is just in one way through things like the underdiagnosis of ADHD and then the overdiagnosis of oppositional defiant disorder and conduct disorder in Black and Latino youth. And what happens is that more severe diagnosis slaps a label on these children that implies that their behavior needs a stronger response or correction, which disproportionately ends up being the justice or the carceral system. Black children and youth with mental health issues are twice as likely as their white counterparts to be arrested and 7 times more likely to be placed in secure settings. And then more broadly, juveniles of color are also more likely to receive severe sanctions by the courts than white youth. And so once again, when we think about white supremacy as an outcome, white youth have a greater likelihood of receiving an appropriate level of hopefully rehabilitative care, whereas Black and brown youth end up cycling in and out of the justice system into adulthood. And so these are the things that we have to grapple with and work against. And it's really easy, I think, to get overwhelmed by how big and deep-seated these issues are. But one thing that I try to remind myself and that I suggest when I'm talking to people about this, about trying to stay engaged in the fight and do your part, is really just to start with yourself. And so I'm going to share a few ways to do that. So again, when I talk about starting with yourself, one of the first things that I suggest to people is really just to practice self-awareness. And I think this can be one of the hardest things to do because it's easy to just say, well, this is my reality, because it is your reality. Your experiences are your experiences. And not a lot of people are trained or socialized to really give a second thought to why your reality is your reality or how it differs from somebody else's. And so you really have to be intentional about exploring your beliefs, your identities, your experiences, where they came from, and also how they affect the way that you interact with clients and how clients interact with you. And then another important thing that you can do is really just to pause and think critically about the information you encounter. I think just generally, if you're thinking about news, social media, all of those spaces, so much of the information we digest, pop culture also, is ingrained with a narrative. And so part of changing narrative is really sharpening your ability to critique that information and think critically about what narratives you're seeing and why. And in module 2, CCR has what we call our Fostering Equity Guide, which I'll share a link to at the end of the presentation. But in module 2, we suggest asking 3 questions. So 1, is the narrative factual? 2, who benefits from the narrative? And 3, who is missing from the narrative? And these questions really enable you to identify whose experience and perspective is being excluded or obscured, and then begin to examine why that might be. And I feel like, you all in your practice can apply this by simply asking questions about how your clients are characterized in notes and referrals, and by checking your own assumptions or the assumptions of colleagues before you're making decisions about how to deal with clients' needs and issues. And then real quick, I just wanted to flag that this graphic that you see on the right was created by an artist named Claudia Lopez, and it's a roadmap of some key strategies and a guide from Open Society Foundation called Building Narrative Power for Racial Justice and Health Equity. And it's a really great resource for learning more about how public narratives operate and what's required to change them. So if you're interested in sort of following this thread a little bit more on your own, there's a link in the bottom. So when they share the slides, you'll be able to dig through that. So we're going to move into breakout discussion now. I think probably if anybody has any immediate reactions or questions, I think we can take 1 or 2 minutes for that. But otherwise, we're going to break into breakout discussions and talk about these 3 questions. But I'll pause for a second and see if anybody has anything that's coming up for you right now. Okay, yeah, it's a lot. This is a lot to process and think through, so that's all good. So before we jump into the breakout rooms, I really just want to acknowledge that, I'm sure as well, let me read the questions first. So one, want you to reflect on your professional experiences and encounters and really think about what racialized narratives you have witnessed. And as you're doing this, there's no need to like name people or anything like that. We're not looking for that, but just think about the things that you've seen and think about how narratives have perhaps played into that. The second question is a little bit more internal. So this is again, lean into that discomfort, is really trying to think about how racialized narratives may have impacted your own approaches or diagnosis or treatment of a client in the past. And then lastly, and a little bit more positively, right? Like, I think in a lot of ways we're again, because white supremacy and structural racism is the water that we swim in and the air that we breathe in this country. I think we're all, for lack of a better word, guilty. We've all committed some transgressions or microaggressions. There's lots of degrees in which I think we can all sort of do some self-reflection about how we have perpetuated these issues. And so I really want to end with thinking about how, just because you may recognize that you have done that before doesn't mean that you cannot and should not make changes moving forward. So really, as you're closing the discussion, think about what small changes you can make to really identify and challenge narratives that are perpetuating racial inequity in mental and behavioral health practice. And so, again, before you go in, just these are tough questions and they really ask you to look at your own behaviors and those of colleagues with a critical eye. And so as you're doing that, just remember some of the agreements of the brave space that we fostered today. Expect to experience discomfort, accept one another's reality, listen with compassion, and challenge yourself, because this exercise isn't meant to induce shame or guilt. It's really meant to spark awareness of how easy it is, as I said, for all of us, regardless of race or good intentions, to really fall into the traps that are created by racialized narratives. So as you have this discussion, please just embrace this opportunity in that light. And I will stop talking now. You'll have about, since it's 3:40 now, let's say about 17 minutes, Alice, and then I don't know, I think that should be fine. And then I have just one more slide of a resource to share back out.
Sounds good. I'll open the breakout rooms and I'll see everyone in 17 minutes.
Thank you.
Well, Kim, this is heavy. It's a lot, huh?
It is a lot. I could tell by how quiet people are.
Yeah.
Okay, so I think that everybody's back. So just in the last few minutes, I just wanted to share that if you want to learn more about some of the work that we do at CCR, and particularly our equity work, this is the Fostering Equity Guide that I referenced earlier, and it has 4 modules, and each one offers a different context, considerations, and tools to really help you improve your ability to foster equity. And so module 1 is really about deepening your understanding of the historical roots of inequity. Module 2 aims to really help you build your skills and capacity to hold space for and engage in courageous conversations about inequity, and particularly about race. Module 3 gives you some really practical strategies for transforming the way that you engage the communities that you work with. And then module 4 is some really good guidance about how to use policy, whether that's big P policy, like legislation, or even thinking about the little p policies that you have to work within your organization in order to create more equitable conditions and experiences for the people that you serve. And so that's all that I had. I don't know if the NTAC team has anything. Just want to say I appreciate everybody hanging in there. This was definitely a heavy topic that we had to Zoom through today, but I hope that you found something useful. And Pamela, feel free, I should have added this here. I don't think that I did. Feel free to send my email address out, and I can also drop it in the chat if anybody wants to follow up later.
And just to say, first of all, these modules are really excellent. I mean, we're hoping, I'm hoping, and they're free, right, Kim? So I'm just hoping that people can kind of take these back to your teams to do some deeper work, because they're really, really thoughtfully put together. And I think what Kim presented today was a very intense teaser for sort of how you can use this work with your teams. We have one more session of our COP. We're going to wait till after the Labor Day holiday. So it's going to be on September 9th. And it's going to be someone from one of the communities that Kim supports, a practitioner from one of the communities that is using the CCR resources and is part of the Building Resilience, Community Resilience Network, who's going to really kind of do a deep dive into some case studies of how they use some of the tools to work with clients in kind of early childhood settings and sort of with families. So I think that last session is going to be, have a lot of sort of really practical food for thought for us. And this session kind of laid the groundwork for that. So we're really excited about that. We are able to, thank you, Kim, and to your colleagues at CCR. We are going to be able to share these slides. I'm sorry that we couldn't share the slides from every session. For some organizations, they haven't published yet, so it's proprietary, but we are thankfully going to be able to save these slides. And Kim has checked to make sure all of these links work. So we'll send these out tomorrow. And Kim's contact information will be there also in case you or your organization or your community wants to do some more work with CCR. I've been just keeping an eye on Kim's team for a number of years. Erin, who's partnering with me on this, and I'm just really excited about this work that they've been doing across the country with practitioners and organizations and communities. It's really exciting. So I don't want to keep people here in the session longer than we promised. So with all that being said, thank you so much for engaging with us. We hope to see you next time. And please answer the survey because we're planning for our next year of programming now. And if folks are interested in doing more work in this space, we really want to know, and we really want to be able to meet those needs. So thank you. Have a good rest of your afternoon.